When assessing a hemodynamically unstable patient for suspected acute pulmonary embolism, particularly when CTPA is precluded, identifying acute right heart strain is critical. The right ventricle adapts poorly to acute increases in afterload, yielding several classic named echocardiographic signs that help differentiate acute pulmonary from chronic right-sided pathologies. Here are the primary named signs to look for. McConnell's sign, perhaps the most famous echo finding in pulmonary embolism. McConnell's sign refers to a distinct regional wall motion abnormality, akinesia or severe hypokinesia of the right ventricular mid-free wall with preserved or hyperdynamic contraction of the RV apex. The pathophysiology is likely multifactorial. The RV apex is anatomically tethered to the left ventricle, which is often hyperkinetic due to tachycardia, pulling the RV apex along for a proxy contraction. Additionally, the sudden pressure overload increases wall stress on the mid-right ventricle, causing relative ischemia, while the apex remains adequately perfused by the left anterior descending coronary artery. While highly specific for acute pulmonary embolism, sensitivity of McConnell's sign is low, about 20%, and it can occasionally be seen in right ventricular infarction. The 60-60 sign is highly specific, up to 94% for acute pulmonary embolism, and is excellent for differentiating acute right ventricular strain from chronic pulmonary hypertension. It requires both of the following parameters. 1. Tricuspid regurgitation pressure gradient 60 millimeters of mercury or less. Note, this is the gradient, not the estimated right ventricular systolic pressure. 2. Pulmonary artery acceleration time 60 milliseconds or less. Because the non-hypertrophied right ventricle cannot generate extreme pressures acutely, a TR gradient more than 60 millimeters of mercury typically points towards chronic pulmonary hypertension. A shortened pulmonary arterial acceleration time indicates rapid peaking of flow due to acutely elevated pulmonary vascular resistance. The D sign is visualized in the parasternal short axis view at the mid-papillary level. It refers to the flattening of the interventricular septum, which pushes into the LV cavity, giving the left ventricle a D shape rather than its normal circular appearance. Timing in cardiac cycle matters. Systolic flattening suggests RV pressure overload. Diastolic flattening suggests RV volume overload. Both systole and diastole, if severe tricuspid regurgitation is there along with pulmonary hypertension, there will be pressure and volume overload of right ventricle, resulting in septal flattening in both systole and diastole. Early systolic notching, obtained by placing the pulse wave Doppler gauge just proximal to the pulmonary wall in the right ventricular outflow tract. Early systolic notching presents a distinct W-shaped or asymmetrical notch in the spectral Doppler envelope. This notch represents brief mid-systolic deceleration of flow. When the RV ejects blood into an acutely occluded high-resistance pulmonary arterial bed, a strong reflected pressure wave travels backward, prematurely decelerating forward flow before it recovers. The early systolic notch is highly specific for severe proximally located pulmonary embolism. Here are the key findings at a glance. McConnell sign, mid-free wall akinesia plus apical sparing. Primary clinical utility, high specificity for acute pulmonary embolism versus global RV failure. 60/60 sign, TR gradient 60 millimeters of mercury or less, and pulmonary artery acceleration time 60 milliseconds or less. Differentiates acute pulmonary from chronic pulmonary hypertension. D sign, Septal flattening in systole or diastole confirms severe RV pressure or volume overload. Early systolic notching, W notch in RVOT pulse wave Doppler suggests high risk proximal clot burden.